and welcome to the special edition of Talk Time. My guest today is Dr. Bhramar Mukherjee, an epidemiologist and a professor and chair of biostatistics at the University of Michigan School of Public Health in the United States. Bhramar is from Kolkata and has been studying and working in the United States since 1996. Dr. Bhramar Mukherjee, welcome to Talk Time.
Thank you for having me.
It's a pleasure. Dr. Mukherjee, in March, you had set up a 15-member interdisciplinary research team from the United States and India, basically from academic institutions, to work on COVID-19 modeling and predictions. You preferred or you chose to study the scene in India and correctly predicted that by the 1st of July, there will be 1 million cases. My question, what next? How is the COVID scene likely to pan out in India in the days ahead, for example, in the next 2 months?
Thank you very much for that question, and thank you for mentioning my team, because the work that we talk about and the work that I present, it's all from my team, and I'm just the spokesperson. So when we set up
Right.
the model in India in March, that then at the time India had only 536 cases and 11 deaths. Since then to now, it has been a long journey, and even after a long lockdown, the curve has not really turned the corner. So we are all wondering when would the peak come, and our projections actually keep pushing the peak farther and farther. So I cannot answer the question because the concept of a national peak is nebulous. And in another paper, we pointed out that some states are going to subside, but there will be new set of states emerging. So there will be probably a wave of peaks cascading through the country. And so it is very hard to predict when the peak is going to be attained. But if we look at the other natural
Yeah.
experiments and other countries which have had a large number of cases, the next million will come much sooner. So our models are currently predicting India will hit 2 million right around India's Independence Day. And I certainly don't want that to happen, but the models are going against my desire and my wish.
Right. You know, a lot of people are drawing comfort with the argument that the per capita caseload in India is low, as also the fatality rate. How do you look at this? Is this a reason for comfort and complacency?
So one thing, of course, if the number of cases and the number of deaths are low, that's reassuring. I have primarily two concerns about the number of
Yeah.
cases reported and number of deaths reported. First of all, I feel that there is severe underreporting, and we have seen it all across the world. The asymptomatic cases are never tracked. Even in terms of symptomatic cases and hospitalizations, there is often misclassification. Because people say this is flu-like illnesses, this is pneumonia, this is pleurisy, but that could be all attributed to COVID. So we really do not know that how to at what extent that number of deaths and number of cases are misclassified. And another thing is that this per capita caseload really does not tell you on the next day in a city like Dibrugarh, city like Kolkata, how many patients are going to show up at your hospital. So for that, you really need to have much more granular regional prediction, which tells you what would be the active number of cases in my city and what is my hospital capacity and how can I scale that up in order to tend to the patients. So that's the calculation that we all need to be doing at a very local level.
Right. We'll expand on this a little later, Dr. Mukherjee. But how do you look at lockdown as a strategy to check the spread? From your study in the last 4 months, what have you gathered? Have lockdowns achieved the desired results according to you?
That's another great question. So there is a wide spectrum of non-pharmaceutical interventions that have been adopted all across the world. And they range from social distancing, wearing masks, hand hygiene, and a lot can be accomplished by following those guidelines as well. Those milder, less intense form of non-pharmaceutical intervention. Lockdown
Yeah.
is really the biggest hammer. And I would say that we do not want to go there unless that's the last resort. We already have had 9 weeks of lockdown. So the lockdown has definitely slowed down the virus. So if you look at the India's virus curve, it has come from like the R, or the basic reproduction number, which is the number of people who get infected on an average from one infected person. That has come down from 3.2 to about 1.25. But the unfortunate or the surprising part is that it has plateaued around 1.25 for the last 1 month. It needs to get below 1. So how can we achieve that as public health and government partnership through contact tracing, testing, treating, but also this other form of
Yeah.
mild interventions? That's the question.
Now, how do you compare? We are talking about lockdown, Dr. Bhramar Mukherjee. How do you compare the situation in India vis-a-vis the United States? Because the United States did not go for lockdowns in the initially. A lot of people are saying that that was a wrong strategy. Look at India. India went for lockdown right from the beginning, and so on and so forth. What is your take? How do you look at it?
So I think that lockdown, not doing the lockdown in United States is having heavy prices. And so if you look at even in Scandinavia, Sweden is a prime example where they did not do any lockdown. In United States, some states actually went into a very strict stay-at-home order. For example, I live in Michigan.
Yeah.
We essentially had a lockdown. But it was very heterogeneous. There was not an uniform national policy. And so there is mobility, there is different kinds of transmission in all parts of the United States. In India, the initial lockdown, I think if it's implemented effectively, it could have a huge impact. So the thing which went wrong for India was that the little time for preparing for the lockdown. So we all know about the mobility of the migrant workers. So the disease could not be localized. So and it spread all across the country. So that's where the problem came, as the lockdown was not as effective. But now we are going into regional lockdown and punctuated modulated lockdown in hotspots in United States as well as in India. So the lockdown, you know that if you extend the lockdown, then the number of cases are definitely going to go down, but that comes at a massive cost to human life. So whether we can afford that, and I would like to say that we have about 400,000 active cases of coronavirus in India right now. Can we really
Yeah.
afford a long enough lockdown to get it to hundreds and thousands so that that can be contained through mitigation and contact tracing and testing? I doubt that. So I think we have to really balance between alarmism and denial and mitigate and minimize our own personal risks. So I feel that there is not going to be a hammer blow again unless things get really, really bad.
This brings me to the question, how do you respond to voices? We say that, more people may die in India due to hunger triggered by lack of livelihood options due to COVID-induced lockdowns than the virus itself. Would you target the virus and deal with it, or hold lockdowns and lack of economic activity responsible for this kind of a situation?
So I think that, so I'm not an economist, but I have been studying this bias trade-off, right, sort of between economics and public health. And I think
Yeah.
that, it has been pitted, the problem has been posed as like, economics and public health pitted against each other. But I think both communities are trying to work together to minimize the loss of lives and the loss of livelihoods. And sometimes, so I feel the policymakers are on a seesaw, balancing between this economics and public health. And as soon as something goes wrong, to scale that policy down and escalate things that are
Yeah.
working. But if you think about Sweden, Sweden did not do a lockdown, but they actually suffered similar economic shrinkage as the other countries, because it's the fear in people's mind which is reducing spending, which is actually reducing the shrinkage of the GDP. That's what happened. So I
Right.
feel that as long as we do not control the virus effectively, even if things are open, it's going to be very hard to revive the economy to the fullest level.
Okay, that's very interesting, economic versus public health. Now you see, the Indian Health Ministry statistics say 86% of cases are coming only from 10 states in the country. So You have already touched on this a little bit. My question is, can there be anything like a possible national peak in India? Or do you think different states or different regions will have different peaks at different points in time?
Yes, so actually, we published a paper back in May on this theme that the national data is masking the state level variation, and we really need to look at the peaks in terms of the different states. And we see tremendous variation. Delhi for the past few weeks have done remarkably well, and it looks like they have actually gone through their first peak. And so it's a very ambiguous concept. What do we mean by national peaks? As I mentioned, that different states are peaking in terms of our projections at different times. So that way, the
Right.
combination of all of this is pushing the national peak farther.
On that note, I go for a short break, but don't go away. I'm in conversation with Dr. Bhramar Mukherjee, an epidemiologist and professor and chair of biostatistics at the University of Michigan School of Public Health. Welcome back. I am in conversation with Dr. Bhramar Mukherjee, a top epidemiologist and professor and chair of biostatistics at the University of Michigan School of Public Health in the United States, talking on the COVID situation in India and her broad prescriptions, how to deal with the pandemic. Now you see another aspect is the greatly worries the people when in the media you read the number of people dying of COVID, so on and so forth. Oh, now, initially it was thought that only people who are geriatric, who are old, usually die quickly if they are hit by the COVID virus. But the point is now, whenever there is a death of, say, 19-year-old, 30-year-old, 40-year-old, it sets off alarm. Now, do you think that every death is attributed to COVID? For example, as you touched a little bit on this in the previous segment. Now, a lot of people may not actually die from COVID. Do you think there is an audit necessary to ascertain the cause of death so as to have a clear picture?
So I think this cause of death data is very important. So I think that in India, even without COVID, in normal circumstances, a very small fraction of deaths are actually medically reported, and the cause of death is
Yeah.
clearly assigned. So this is a problem with our data. And so with COVID, this problem is really hurting us. India in general has been a very data deficient environment, particularly when it comes to health. So if we really had
Yeah.
death data, historical death data, historical data from flu and influenza related illnesses, as well as severe acute respiratory illnesses, then we could compare what is happening this year compared to past years. But it's incredibly difficult to get national data, even regional data, to do those type of calculations and comparisons. And so I would say that, the deaths, so COVID is a very deadly virus in the sense that it's highly contagious, it has silent infections, and also the severity spectrum has been very unusual. So even in the United States, there have been the initial symptoms of fever and cough and chill. Later on, people have discovered many other symptoms as well, and the complications have been
Yeah.
strange in some particular cases. So the scientists are working very hard, I can say that from my own experience in Michigan, to predict who are going to be those people. Is it related to their genetics, their comorbidities, who are going to have severe outcomes? But it's also important to get tested on time and get the treatment on time. So in India, what I have heard many times is that the treatment and the oxygen and the ventilation is not being accessed at the right time. And the access to healthcare is not equal in the rural area versus the urban area, in across different socioeconomic strata. It's not the same.
Yeah. Right. Now, that brings me I'm tempted to ask this question. Do you predict a situation in India when the healthcare system may just have no more capacity to deal with the pandemic? Because you said that, yes, the rural-urban divide is really, really high as far as health infrastructure is concerned. So do you think a day may come when the healthcare system may not just handle it anymore?
So I am worried about it. So far, I think it has only happened for a few days in hotspots. And as soon as that has happened, there have been severe measures, increased testing, increased healthcare capacity. But I think we have a long way to go and a lot of work to do. It's a long and painful crisis, and it's just not headline management. So the problem with this virus is that I really wish, like, I could do a cartoon of this, that the virus is running and we are falling behind by 2 weeks and 4 weeks, because what we are seeing here today, the virus has done its work 2 weeks ago. So the deaths that you are seeing today are the work of the virus from 4 weeks ago. So we are constantly falling behind. We are constantly chasing the work of the virus. So what I want to suggest is really look at the data at a very granular level. And as soon as there are suggestions and evidence of an outbreak, then really have stringent measures and high alert. I do think that in the rural areas, it's going to be a challenge. So there could be, some other countries, they have dealt with it in terms of taking COVID testing mobile vans to the villages or
Right.
creating a temporary COVID hospital. Another thing which is extremely important is to create centralized isolation and quarantine facilities. The households in India are not very well suited for self isolation. So once a family member gets
Right.
infected, everyone in the family gets infected, and also some neighborhoods are very tightly knit. So whole cluster of transmission happens. And we have seen that in some villages in India, the super spreader events. And we really do not know who these super spreaders are. But what we can do is to minimize our contact with people and make sure that we are not in indoor spaces, we are not in large gatherings, we are washing hands, we are wearing our mask. The public can do a lot to minimize this risk so that even if people are falling sick, it happens at a gradual level and not everyone falls sick at the same time, so the hospitals and the doctors cannot take care of the patients.
But then the natural question that comes to my mind is India has take look at Mumbai, how they have controlled the spread in the biggest slum, that is Dharavi. Does it surprise you? How do you explain this? How did Dharavi did not become a real huge issue as everyone predicted in the initial days?
So that exactly that's an excellent question, and I have been mentioning this in all my work as well as all my lectures. That Dharavi is really an inspiring example, and that shows that different places in India, different communities in India, are going
Yeah.
to beat this virus through different strategies. So first of all, Dharavi shows that community engagement, communication, and trust and participation from the members of the community is extremely important. Temperature checking. If you cannot
Now,
test everybody, you at least do regular temperature checking and symptom tracking. And the healthcare workers have adequate PPE, so they are not afraid to go and do their work. Another thing which is key, I think, is the centralized isolation and quarantine. Because in Dharavi slums, it's very hard to do self isolation. So really taking the infected person out of the household minimizes some of this cluster transmission. I think Dharavi, there is no excuse for the rest of us not to do this. If in a low resource setting where the odds are
yeah.
really stacked against us, we have been able to turn the curve and bend the curve and turn the corner.
How would you tackle community spread? Would you tackle it differently than people who are already in quarantine? So, for example, lakhs of people came from one part of India to another, and they were immediately put in institutional quarantines. So it was easy. Even if they tested positive, they were already in quarantine after having landed into another state, and then they were taken to hospital. But when there is a community spread, does the strategy change? As an epidemiologist, how do you deal with a community spread? What are your primary recommendations?
Yes, so now the disease is very widespread. So again, I think that the recommendations are very similar. What is important is to have adequate number of tests. So you saw that in Delhi, by just increasing the number of tests, so Delhi has done the highest amount of in terms of testing, in terms of proportion of population tested. So the all of India is about 1.1% of the population has been tested. In Delhi, it's about 3.5% to 4% people have been tested. And the effective reproduction number has been staying around zero point 0.8 for the last 10 weeks. I have been watching it like a hawk. And so it shows that if you actually are able
Yeah.
to identify cases early enough and isolate them, and the whole community wears mask and social distancing, even if you have community spread, and centralized isolation and self quarantine is very important in this situation, then you can actually mitigate the disease. So I think that that's what I'm going to recommend. And if the public has a strong role to play in public health, we need cooperation. And the government actually really need to coordinate the different sectors, particularly healthcare and public health and social support and financial teams. These four sectors really
Right.
need to come together and rally around a common good.
I'll take only a few more minutes of your time, Dr. Bhramar Mukherjee. Now, you have put a lot of emphasis on increasing testing in India. As you have just said, little more than 1% of the population has only been tested so far. My question to you: do you have a figure? Test, do you have a figure? Testing should ideally increase by how much, within what time, for us to get a good idea of how things could unfold?
So that's what I'm saying. So we actually created a metric in our paper. We proposed that in order to get the test positivity rate around 2%, 3%, which some of the successful countries have seen, how many tests do you need to do? And so according to that, India still needs to do about 40 million more tests today, according to that metric. So what if the so I am a very realist person. I can do my mathematics and give you numbers, but that may not be feasible.
Yeah.
So what I think that India can do is to, of course, maximize testing capacity, but also do this symptom checking, symptom tracking, particularly in communities, in rural communities, using grassroots level community health workers to do even door
Yeah.
to door symptom checking and contact. If you ask people to maintain a symptom diary and a contact diary, because often people forget who did you meet throughout the whole day. Simple measures. This virus is very complex, but the measures that actually have been successful in different countries are simple to adopt. It requires change of human behavior, but it can be done. And it has been shown in many places in India and across the world that we are not defenseless against this virus.
Are you also worried about the impact of COVID on humans due to COVID related stress? Because everyone is talking about the impact on the economy and so on and so forth. But what about impact on human, mind? What about stress because of COVID? That's a huge problem.
And actually, this is a very important issue, and I think there are two aspects to this, two angles to this. One is that the lockdown created a lot of problems in itself due to social isolation, due to lack of access to not care for non-COVID related reason, the delay in care. Even in the United States, we are
Yeah.
seeing that cancer patients are delaying their chemotherapy, and as a result, their cancer condition is worsening. So it will take us a long time to really evaluate the cost of COVID. So I feel that the cost of COVID has come in so many different realms of our life. It's very hard to quantify. I wish I could do a cost benefit model where the economic costs go in, the COVID
Yeah.
costs go in, but then excess deaths due to other things. But you have to remember that some other diseases have also gone down. For example, any infectious disease, because we are washing our hands, practicing social distancing, flu, influenza, those type of diseases have really gone down. And on the other hand, what has gone down is also what I think is very important, interestingly, is that, like, any kind of secondary infections that we see in the hospitals that have gone down,
Yeah.
accident related deaths that have gone down. But what has really increased is mental health, stress, anxiety, delay in care. And I think we really need to put more effort on providing psychosocial sustenance to people.
Now, how do you de-stress, because you are among the top researchers on the subject across the world. Dr. Bhramar Mukherjee, I have read reports that you read a lot of poetry, W.B. Yeats, Emily Dickinson, and so on and so forth. Are you into too much of poetry? Are you also writing poetry these days, or don't have the time to do so?
Thank you for that question. So I grew up in a very liberal arts oriented household. My father was a professor of
Yeah.
English literature and an actor on Calcutta stage. So I grew up in a very artsy environment. And it is true that, when I'm doing the work of science, I'm trying to help come up with the projections. This is my public service as a quarantined health data scientist. This is the least I can do for my homeland. But when you think about the sustenance for the soul, and we are all like, in a similar position, quarantined, isolated. My main anxiety is about my parents are back in Calcutta. When am I going to be able to visit them? My father is an octogenarian. He's a theater actor, so he doesn't know when live theater will be back again. So my very close friends are in Delhi and in Calcutta, and so they're all suffering and anxious. So this whole thing, when we are so alienated from each other, art can really bring us together. We can really read a poem
Abs-
together. We can get inspired. We can get healing for our soul. And
yeah.
so I tend to write in Bengali and also read poetry from all over the world in order to keep my inner sustenance and the peace going. Because I'm hopeful that, if we can sustain ourselves emotionally, socially, then and give the scientists some time to get to the vaccine and the treatment, that will be the best way to move forward, because there has been tremendous progress in that world. And so we just have to hang in there. It's a long and painful crisis. So we need some, resilience, solidarity, collective sacrifice, social responsibility. Some of these big words may seem very lofty, but when humanity has been a crisis historically, we have gone through that together, resorting to these big values and these big words.
Absolutely. Very well said, Dr. Bhramar Mukherjee. I mean, in the moral of the story is that you have to have patience there, because there will be always light at the end of the dark tunnel. My final question: when will COVID possibly end? Because everybody is asking this question. No one has the answer. Do you have one?
So I think that, I don't have an answer. We do not really know, but all we know is that, if we can contain the disease, if we can keep the growth of the diseases within containment, and also the number of deaths, if we can control that, because only a small fraction of COVID infections actually end up in the hospital or have a fatal outcome. I do not want to undermine that, because every statistic is a human being and is a loved one for someone. So this is really
Right.
traumatic time. But what I want to say is that there is hope, because the vaccine has been really accelerated. So if by the beginning of next year, there is a vaccine, and what they're doing is to really processing the doses of the vaccine simultaneously as the trials are going on. So we probably have a vaccine. If we do have that by next year, it will still take us some time to inoculate a large number of people so that we can have herd immunity. So it's going to become a part of our life, but we are not going to be so devastated, because we'll learn how to manage this, because human beings are extremely resilient. We are
Absolutely.
adapting. If you think about the
Absolutely.
last 6 months, how we have succeeded in adaptation, that gives me hope that we'll learn to manage it better, and eventually we'll find a solution to this problem, like we have for all other major crises in history.
Absolutely. We hope that solution comes sooner than later. Dr. Bhramar Mukherjee, thank you very much for your time and for being so clear in your thoughts to explain to my viewers as to what the COVID situation is in India and, of course, across the world. Stay safe. And once again, thank you very much, B, for
Thank you
being on
very
Talk Time.
much. I hope all your viewers stay safe and do the right public health things.
Thank you very much indeed, once again.